guidelines for HIV during pregnancy, labor, and even postpartum is very, very crucial. So today's topic is HIV in pregnancy, guidelines for management, which will be a panel discussion moderated by Dr. Rekha Bharti, madam. And before we move on to the panel, I would like to call upon Dr. Anju Soni, madam. Madam is the president of Indian Menopause Society, past Secretary General of Indian Menopause Society, Governing Council member of ICOG, member of India CCM, chairperson of HIV and AIDS Committee, FOXY. She has been a recipient of multiple awards, ICOG Excellence Award, Illuminous Alumni Award from the Chief Minister of Rajasthan, Chikitsa Vibhushan Award, and Dr. Mehru Dara Hansotia Award for Best Committee, that is for HIV and AIDS Committee of the FOGC. And ma'am has many, many publications to her credit. And ma'am has released an updated technique guideline on HIV positive pregnant women. Welcome, ma'am. Over to you.
Thank you, dear Neelanjali, for your kind introduction. And you all know that I have been working with HIV for last more than 4 years, and still till now also I am working. I was there in the meeting of CCM yesterday only. So I am very passionate about HIV, and the Wisdom series could not have been complete without talking of HIV women. And it is so very important. And I would like to welcome all of you. So why are we talking about HIV is what I'll just say in, this thing. Are my slides visible?
Yes, ma'am.
Yeah. So as all of you know that we have all been through a very, very difficult situations of our life. And that has been COVID-19, and that has given us lot of introspection, lot of thought, which has gone through all of us, I'm sure. And these lines, just as one might predict for a disease that is not yet fully understood, as well as extremely recurrent to treatment, has provided a large-scale occasion for metaphorizing illness. And these lines were said way back in 1989 by Santang S. in his book AIDS and its Metaphors. And today, after almost 4 decades, more than 4 decades, we are still there. We all know that there are people who have lived COVID-19 crisis and also have seen AIDS crisis. At that time, AIDS was considered like a death sentence, but with modern medications, we have been able to control this disease, but the medicines have to be taken throughout the life. There have been a lot of similarities between SARS-CoV virus as well as in HIV, but there is a big difference also. The big difference is that COVID-19 has been controlled by vaccination, while in spite of so much of research and data, we have not been able to come out with vaccine because this virus of HIV is a very, very notorious virus, and it changes structure more than 100 times in 24 hours. So there has been no breakthrough for the disease, and we don't have any vaccination, and we have to take antiviral therapy throughout the life. So why this period has been there for longest time? Because it was first discovered in 81, virus identified in 83. The history says, and in 1987, ZUA therapy was initiated. In 1990, it was controlled in the developed world. But we were thinking that it is not going to come to low middle income countries. But here there was a blast all over the developing countries. And so global and national responses took place, and there was an MDG goal of 456 to control, diagnose, treat, and control HIV throughout the country, prevention. And then in 2007, dual elimination started with elimination of syphilis. Again, last year, we have come again back to the same rule from NACO. We are talking of dual elimination of HIV as well with its resurgence. And in 2014, the EMTCT initiative was taken up and 17 countries were validated. We also had a goal to control it by 2020, but because of the COVID crisis, now the goal is shifted to 2030. When we look at the global statistics, about 25 million of people were on ART and 37.5 million living with HIV, 1.7 newly infected, and 0.7 million died from AIDS-related illness, and 75 million were infected since start of the epidemic, and about 32 million were died because of the AIDS-related illness. When we look at the India scenario, though the prevalence is very low in our country, 0.34%, but we are the third largest number of people living with HIV in the world. That's about 2.1 million. And women account for 40% of the total infections. 21,000 children are infected every year. Nearly 5% of these infections are attributed to mother-to-child transfer, and 70,000 children are there who are living with HIV under the age of 15, though some are infected by unsafe injections and blood transfusions. So out of 27 million pregnancy every year, 21,000 are estimated to be among the HIV positive women. And UNAIDS realized that the goal of 1990 was not enough to control HIV. So they changed the target in 2021 to 95, 95, 95. And India in 2021 was 77, 84, and 85. Though we have done a lot of improvement, and in 21 and 22, we had 92 to 93% states who were having a good testing. And these are the magnitude of problem which I just told you. So we all know that the prevention is there at primary, secondary, tertiary level. Primary refers to activity focused on preventing uninfected people. Secondary is aimed to enable people to stay well. That means testing to allow people to know their status, their welfare, rights, and advised lifestyle behavior, and anti-discriminatory therapies. Coming to the tertiary prevention, it aims to minimize the effect of ill health experienced by someone who is symptomatic with HIV disease, that is prophylactic use of drugs and complementary therapies. So our aim is to reduce sexual transmission, reduce and prevent mothers from dying and babies from dying and becoming infected, reduce and ensure that people living with HIV receive treatment, and to reduce, protect drug users from becoming infected, to remove policies and practices, stigma and discrimination that blocks the effective response to AIDS, and to stop violence against women and girls, to empower young people to protect themselves, and to enhance social protection. So looking into this view, I wanted the best person in the country who has done so much of work in the field of HIV to target this topic, Professor Rekha Bharti, who will be, with lots of experts from all over the country, will be dealing with very, very important issue. And I'm sure all of you who are there would definitely gain a lot of insights from today's panel discussion. Over to you, Dr. Sini or Nilanjali, whoever. Please introduce the experts.
Dr. Manisha, are you there?
Yes, I'm there.
Yeah.
Please, thank you.
Very good evening to everyone. Thank you, ma'am. Thank you, Dr. Anju, for such a elaborate introduction and the need of the hour of this topic. And I'm personally looking forward to listen to ma'am. Just 1 second, ma'am. Actually, Dr. Nilanjani had to leave for her own webinar somewhere, so she has asked me to.
Oh, I can take over, Dr. Manisha. Shall I introduce? Yeah, I can.
Dr. Nilanjani, are you there?
No, yeah, I can introduce.
Okay, then please continue. Please continue with that.
Sure. So we move on to the scientific session, the panel discussion. And ma'am, we really applaud your passion for HIV. Anju ma'am, we really, really applaud that. So we welcome Dr. Rekha Bharti ma'am. Ma'am is Professor.
Nilanjani, 1 moment. May I just request all the faculty members to rename themselves?
I agree.
Yeah,
It's just
because
scattered all over.
the camera is also not on, and then we just are not able to get who is there and who is not there.
Yes, yes, we have done it. It's done.
Okay, thank you, sir. Thank you so much.
Thank you, everyone. So I introduce Dr. Rekha Bharti, madam. Madam is a professor at VMMC and Safdarjung Hospital. Ma'am is the nodal officer of PPT, CT, and STI. And as told by Anju Soni, ma'am has worked tremendously in the field of HIV in pregnancy and its prevention. Welcome, ma'am. I also take the opportunity to introduce the panelist, Dr. Brijbala Tiwari, madam. Madam is the past president, Indore Obs and Gynae Society. Professor Lola Ramachandran, madam. Madam is the past president, Thrissur Obs Gynae Society. Dr. Devashri M, madam, secretary, Rajamundry Obs and Gynae Society. Dr. Nagajar of Chandrapur Obs and Gynae Society, Dr. Ram Prasad De Sir, Vice President, Bengal Obs Gynae Society, Dr. Reshma C.R. Madam, Professor, Government Medical College, Thrissur, Dr. Selva Rani Jay Raman Madam, Secretary, Dindigul Obs Gynae Society, Dr. Udayan Sarkar Sir, HOD, MGM Medical College, and Secretary of Siliguri Obs and Gynae Society. I welcome you all, and Madam, please go ahead with the panel.
Thank you, Dr. Nilanjani. Thank you so much for the kind introduction, and thank you, Dr. Anju Soni, for giving me this opportunity. And actually, this is also one of my passion, like Madam knows, and like Madam, I also like to work on HIV a lot. And I welcome all my esteemed panelists, the experts who are there to discuss this topic. Can I have my slides here?
Yes, ma'am.
Yeah, please share my slide. So as we all know that the first case of HIV was diagnosed in 1981, and in India,
Yeah, thank you.
and this
And two
HIV.
faculties are still.
Now, go on to the next slide. You can just keep shifting the slides. Yeah. So in India, the first case was reported in 1986, and how the HIV epidemic has gone in India and now it is reducing has already been discussed by ma'am. Next slide, please. So we know that when the first case was diagnosed, that time only National AIDS Committee was formed, and after that, NACO, the organization, came into picture in 1992. And since then, there was NACP 1, 2, 3, 4, and you can take to the next slide. And now we are in the next phase. Next slide, Lily Ji. So the NACP 5 has started now. So as you see, like initially the focus was only on providing information, educating people, and now it is considered as a chronic manageable disease. And as the ma'am said, the elimination now is targeted to be reached by 2030. So can you just shift on to my next slide? So let me see the treatment of HIV, how it has passed so many stages. Like to begin with, in 2004, we were giving ART only those people who had CD4 count of less than 200. And now in 2017, the recommendation came as treat all regardless of CD4 count. Not only antenatal patient, everyone who's HIV positive, they get the treatment now with whatever CD4 count is there, even with a higher CD4 count, because we have to convert this into a chronic manageable disease, and we have to stop the transmission of the disease. Can you just take for the next slide? So this is, how the, can you go on to the next slide? So these are the recommendations. And as you can see, like in 2013 ART guideline, the recommendation of ART was on TL, tenofovir, lamivudine, and efavirenz. And now in 2021 guidelines, the recommendation have changed to dolutegravir in place of efavirenz. So this is, what we are going to discuss, like how this management guidelines, why they have changed, why this change has been brought, and what are the advantages of it. And the next slide, please change to the next slide. And this, madam has already discussed the elimination of mother-to-child transmission. So why basically these webinars are being conducted, so that we all are aware that what targets we are going to achieve this target, what is our contribution as obstetrician to this field. So more than 95 antenatal women to be registered. Whatever we estimate, more than 95, and we know our healthcare system is trying to take care of this factor. And then more than 95% of the estimated pregnant women should be tested for HIV. So this is, our responsibility. And more than 95% of the positive women who test positive, they should be on ART. So this is also one of the responsibility we have to carry forward, that we have to link these women with the ART clinics through our PPT-CT or ICTC centers. Goal has to be achieved, and we definitely wish to eliminate at least the pediatric HIV by eliminating mother-to-child transmission by 2030. So we go on to the questions now that our panelists are going to we are just going to elaborate on these things only, the guidelines of management. So just to discuss that, we have made few cases, few basically situations have been prepared to discuss the complete management of the women in pregnancy. So can you please go on to my next slide? Yeah, so this is the case 1, and this patient is, can I have Dr. Tiwari to answer this question? So a patient, she is married for 2 years, and now she's planning conception. Although in India, though in private sector, we do see people coming for preconception counseling, but we know this fraction of people coming for this is very low. But if a person comes for preconception counseling, is HIV part of preconceptional counseling? Dr. Tiwari, could you please answer this question?
Good evening to all, and thanks, Dr. Anju ma'am, for giving me opportunity. So basically, whenever the patient coming for preconception counseling, as rightly said by you, that very less number of patients coming for this. But whenever a young girl coming for a premarital counseling, and mostly they are coming for preponing or postponing their dates, coinciding with the marriage dates, then that is the time we can take this opportunity to counsel them regarding contraception as well as preconception. So whenever patient coming for this, along with taking history, any history of blood transfusion, chronic illness in family, and rubella vaccination, it is the time when we are telling them about this HIV and hepatitis B testing along with TSH and sugar testing. So this is like I am practicing in private. So we are advising them to go for these few tests.
Very right, Dr. Brejwala. This is also one of the opportunities. So basically, preconceptional counseling in India is more of opportunistic screening, where for whatever reason, the woman comes to us. We should take this, we should advise them to get all the tests which are recommended for preconceptional counseling. And can just highlight also that how this transmission can be avoided if we start these, we actually start ART to these patients. Can you please switch on my slide? Move forward my slide. Yes, next slide. Next slide, please.
So there is definitely a risk of transmission from mother to child during pregnancy if mother is not diagnosed or she is not started with treating, and during postnatal period when she is doing the breastfeeding. So we have to counsel, we have to do the test, and if it comes to be positive, so pre-test counseling, post-test counseling. So we are sending our patient to ART center in medical college, and they get proper counseling there. And then if she is planning pregnancy, what precaution she need to take, on what ART drug they have to be kept. So there are certain percentage if patient is not on any ART treatment and she is feeding her baby, then the chances
are the previous slide. इससे पहले वाली slide लगा दो, उसमें transmission rates हैं. Yes.
So the chances of transmission, if she is not on any ART treatment but feeding exclusively, then it is around 35%. And if no ART without breastfeeding, baby is on top feeding exclusively, then the chances are 15 to 25%. But if she had been on any single drug, ART drug, then the risk is reduced. And so if she's on 3 ART drug, and no breastfeeding, that then it is very, very less, 1% only. But if she is feeding, still there is chances of mother to child transmission in there, but it is reduced to so decrease, like from 35 to 1% or 2%. So it is very important to counsel women if we get an opportunity preconception and during first visit, if not preconception then.
Yeah, thank you so much, Dr. Brajbala. So now my next question is to, please shift the slide. Our next question is to Dr. Lola Ramchandran. So this is a patient which we were talking about. Now she is tested positive for HIV. So what is the ART regime that we would like to start her on, because she's planning to conceive? And with the ARV drugs that we have just talked about, is there any need for additional counseling? Sir, hello? Am I audible?
Yes, madam. Clearly.
Yeah.
I think
Is Dr. Lola there?
I think not there.
Anyone wants to take up this question?
Okay.
Yeah.
Hello. Hello.
Yeah, hello. Yeah, welcome, sir.
Yes.
Please.
Yes. So once the C is tested positive, so the patient must be attached to the ANM, the NN of the ART center, and the ART drug should be also prescribed as the protocol, NACO protocol guidelines. But thing is that the patient may ask a question that she is absolutely healthy. Why she should take all this drug? So other than what you have told already, the transmission from the mother to child, so make it clear and try to convince her that it is not only beneficial to her, but it also gives what which happened already has been happened, that he is tested positive. But if he started the drug in right time with right regime, then baby might be of the not having free from this HIV. There is a possibility because chance of mother to fetus transmission is substantially reduced. You start the drug in the right time, the right dose. So with this counseling, that it is not only for you, but it is better for your upcoming baby. That is also important. Should be also stress. That is why I want to highlight here. Yes.
Yes.
Hello.
So
Yes.
yeah, yes, sir. So counseling, what drug regime we would like to give this woman, and there is need for any additional counseling?
Ma'am,
yes.
If I can pick up that question, normally TLD is started.
Yes.
Tenofovir, lamivudine, and dolutegravir. In the recent past, we used to use TLE, but nowadays efavirenz has been changed to dolutegravir. And the risks, the counseling that should be done in a few studies, it has been mentioned that dolutegravir may give rise to neural tube defects, especially in the early pregnancy. So that counseling may be done, but then the recent studies have said that it's very little. The chances are not much raised, neural tube defects or teratogenic effects. So mother has to be explained that is the best drug available, and if she doesn't want it, then maybe we may have to change the drugs.
Yes. Can you please shift my slides? So it has been already said that TLD is the best regime to be started. Next slide. Can you take to the next slide? We'll be talking about the advantages of TLD and this neural tube defect. So although the risk is not very much increased as compared to the general population, it is up to 0.2% in general population, and with TLD it goes to 0.3%, but still we have to inform the woman about this small increase in the risk and take her consent. Although at the same time we should be telling her the advantages of dolutegravir regime, but still if she is not willing to take this risk, then we have to go on to the alternative regime, which is TLE, which we were previously giving. Next slide, please. So this is, if she opts out of TLD, then only we give TLE. And those women, as this is the previous recommendation only, that if a woman has already been exposed to NNRTI, any kind of NNRTI, so these women, instead of efavirenz, should be given protease inhibitor. So this is one thing which was there in the previous guideline. If she chooses, TLE regime is still there. Next slide, please. So this is basically slide showing the various stages where of the cycle of this virus, where these drugs they are going to affect. Next slide. You can go on to the next slide, please. So next question is Dr. Devasri. Madam, can you see when can she, like now we have started ART, like suppose she wants to continue with TLD, we have started TLD and she says that I want to, because she had initially come to us for preconceptional counseling. So when can she plan conception after starting ART?
Good evening, ma'am.
Yeah, Dr. Devasri.
Yeah, good evening, ma'am. Am I audible, ma'am?
Yeah, you are audible. Please go ahead.
Okay. She can start it after 3 months, ma'am. 3 months we will wait for the tolerance of the drugs if provided if the CD4 count is greater than 350. But if the CD4 count is less than 350, we would like to wait for 6 months, ma'am. Again, repeat the CD4 count and take a decision regarding, or counsel her regarding the further conception plan.
Yeah, please shift to the next slide. So very well said that it depends upon the CD4 count, because we assume that if CD4 count is higher, the virus load, although we should be doing the viral load, but we do not in our country, we are resource limited country. So everywhere this may not be possible. So we still go by CD4 count. If it CD4 count is more than 350, then she just waits for 3 months to tolerate these drugs which are being started. And if it is less than 350, we repeat after 6 months. If it is more than 350, she can go ahead with conception. Otherwise, we have to review that what went wrong by the CD4 count is not has not picked up. Yeah, next slide, please. So, Dr. Devasri, one more question I have for you. What are the advantages of giving dolutegravir? Like there is, we talked about, there is a small risk of having neural tube defect more than other drugs. So why still we want to give dolutegravir? Please shift on the next slide. You can put up the next slide? So
efficacy, ma'am.
Yeah.
Yes, efficacy, it suppresses HIV much earlier, and the cross drug interactions is very less. And the thing is, it is generally well tolerated and it will have fewer drug interactions, and it is also having a high barrier to resistance.
Yeah, so the main thing is that it suppresses HIV much earlier and it has a barrier to the resistance. So this is very important point, because in resource-rich countries, whenever they start ART, even in the patients who are newly diagnosed with HIV, they are doing resistance testing. And only then they are starting the drug. But in resource-limited countries, it is not possible. So we have to go on to a drug which, suppresses the viral load rapidly. So for that, these integrase inhibitors, they are very good, supposed to be very good. And dolutegravir is very well tolerated. And it can also be given in patients who have tuberculosis, although the dose you have to increase there from 50 OD to 50 twice a day. And if patient has HIV-2 infection, so it is effective for HIV-2 infection. So this is one of the advantages that it gives, that it covers HIV-2 infection. And safety also, except for the small risk of neural tube defect, which also we talked about, is not that much. And maybe with more women taking it, more study results coming up, probably this result will equal to the general population. So that is why we prefer giving dolutegravir. So can you go on to the next slide? Yeah, the next question. You can shift to the next question. So additional advice, like if we talk about, so this is, women who are, where the partner is also positive, still we have to tell them to use barrier method, because both of them can be in different phases of the viral cycle. The load may be different. So that is one important thing which you have to tell them. And they can have intercourse unprotected only during the fertile period. So that way, we can prevent the increase in the viral load in the woman who's planning pregnancy. Next slide. Yeah. So so there is another situation, and I would request Dr. Nagina Naidu to please answer this question. This is a primary gravida who comes to the antenatal clinic with 2 months pregnancy. So what is the strategy for HIV testing you will follow when she comes for HIV testing? So what do we call this strategy?
Yeah, thank you, ma'am. Thank you for the opportunity. And we are the very smallest society of Maharashtra state. So thank you for the opportunity, including us into the national webinar, which you are taking, and you are taking along it very well. Thank you, Soni madam, Rekha Bharti ma'am. And for the answer, definitely whenever any of the ANC patient comes to you, who go for ANC profile routinely, and which is including HIV testing in it. And definitely if some questionnaire come from her that why I'm supposed to have the HIV treatment testing, so definitely we have to tell her for the to and fro's of the HIVs that you should definitely your baby should not be affected with it, or any of the dire situations come over, you should be aware of that, what exactly your status is. So we will set her for HIV testing and the benefits which she's getting from it, and we'll going for the definitely counseling part is the main part, which they will think that why I am doing HIV, then I'm a housewife or I'm a good routine, good lady, why I'm going to the HIV testing. The proper counseling is needed in it.
Yeah. So we call it as opt-out counseling. As you said that we, along with the other tests, we are going to give the test for HIV also. And the counseling for the HIV in the antenatal women is done in group. So here we do talk about, the benefits of HIV testing, and also, the ways to protect themselves. Like we have to tell that to the women also. And if a woman tests negative, that also we have to tell her about that, how she can remain negative for rest of her life. And the strategy that we take on is the strategy 3 of the NACO. Can you please shift on the slides? Yeah, next slide and next slide. So come on to, yeah. So if you see strategy 3, this is the strategy which is followed for the patients who are asymptomatic. So all our antenatal women who are coming and we are routinely testing them, they are actually asymptomatic. So we do test 1. So test 1 negative means woman is negative. But if it is positive, like it is not like the other strategies where the patient is symptomatic. So if it is positive, one test is positive, we do not declare her positive unless all 3 tests. So test 2 and test 3 is also done. So test 2, test 3, all positive, we report her as positive. But if one test between 2 and 3 is negative, that is indeterminate testing. But if only one test was positive, rest 2 were negative. In low risk women, we can consider them as negative. But because woman is antenatal, so here we will do repeat testing after 3 months. So all other categories except for all 3 positive, women will be tested after 3 months again. Okay, so this is strategy 3 of the HIV testing. So can you shift to the next slide, please? So we have tested this patient, and the patient has been tested with all the 3 tests, and now we label her as HIV positive. So how will you manage? Is there any special antenatal care that should be provided to these HIV positive women?
Yeah, indeed, there is. First of all, as soon as she is positive, she must be definitely very panicked. How come me? Why me? She must be having that. Firstly, the counseling that you will be okay, your child will be okay, don't worry. And the second question which she'll be asking us, why me and how come me? So definitely we have to test the second partner also, the half of the partner, what exactly is the cause maybe. And then definitely we'll send her to the ART center, which is in the government medical colleges. And then we have to go for her CD4 counts, what the ART centers which they are going to do for the needful, the CD4 counts to be done. And as soon as the CD4 counts are done, her clinical stage to be monitored, and likewise ART should be started to her. And definitely in the initial phases, we have to see the RNA plasma copies should be in there. And 2 to 4 weeks of initiating the ART. Monthly again, we'll go for the RNA levels if they are detectable or not detectable. And if they are undetectable, definitely we'll follow after the 3 months testing during again pregnancy. And others are the general ENC counseling, including the family into it. Due to her also, the family should not be affected, or maybe the family is already affected, having load of virus. Again, that double load of she should not be given by her husband again. So we have to restrict her for the sexual activities if she's having any. So we'll do likewise.
Yeah. So can you please go on to the next slide? You have moved to the previous slide. आप हाँ और आगे आ जाइए. दो slides आगे कर दीजिए question के बाद. Yeah, next slide. So as already been said, we'll be linking the patient with the ART center, CD4 count testing, and the plasma RNA copies. At few centers they are being done. Maybe all the centers are not doing. So if facility is available, they are done and repeated to see whether they have come to the undetectable levels. Next slide kar dijiye. So yeah, and so test on ART, we all know that when the antenatal patient is coming to our antenatal clinic, what all routine tests we are doing, like as CBC count and urine routine microscopy, we are repeating in each trimester. And in the low risk patient, and other tests which we routinely do. In addition to that, CD4 count is done every 6 months. And if she is receiving tenofovir, because that is one of the backbone drug, so creatinine count, creatinine levels once the ART is started, and thereafter every 6 months. If with efavirenz, we have to monitor lipid profile. So that is basically not as much important during pregnancy. So that if the patient is not antenatal pregnant, then later on every yearly she can have lipid profile done. So next slide, please move on to the next slide. So my next question is to Dr. Day, that what is IPT, isoniazide preventive therapy, that we are talking about, and what are its indications and contraindications? Next slide bhi kar dijiyega, please. Dr. Day, could you please answer this question? Is he there?
Yes. Hello. Am I audible?
Yes, sir. Yes, sir. You
Yes.
are audible.
INH prophylaxis for HIV patient is that it is for the tuberculosis prophylaxis. Before going to that, there is a two and tuberculosis disease. As we are living in India, the prevalence of tuberculosis is so high. There is so many % having tuberculosis infection, but they are not actually disease. But the disease happens when there is a agent and host. There is a conflict. That is when the host having the suppressors of immunity, like HIV patient. So there is a chance of flaring of the tuberculosis from infections to disease. But keeping in mind, the INH proposal to be given those who are actually not disease, but they are susceptible for the disease, tuberculosis infection. So all 4 negative, that is the symptoms of tuberculosis, they are given or not negative, because if this is positive, they must be excluded for the tuberculosis, and then need full-fledged course of short course chemotherapy of tuberculosis. That is the fever, cough, night sweating, weightless, all these things. If there is not present, then you can give this type of the INH prophylaxis of the UDAS dose of 300 milligram. And now, keeping in mind that it should not be given to those patients who is already florid tuberculosis disease, or who is having already that patient all the active tuberculosis or multi-drug resistant.
Yes.
Needs to treatment for tuberculosis as per the National Tuberculosis Elimination Program. Yes. Hello.
Yes, sir. Yes, sir. Yes, sir. Very well said, sir. And this is very important. So why we should know it? Because these treatments, these prophylaxis are started by the ART center. And many times when we see the patient is thinking, if we are not aware of this IPT, we would wonder why the woman is getting IPT. So it is very important. And one more important thing is that it is safe in pregnancy, irrespective of gestation, it has to be started. Like this case, who is 2 months amenorrhea, this patient would also be started on IPT, because we assume that in India, everyone has latent tuberculosis. So if they are not tubercular positive, they're all in the latent phase. Yes. So can you please change my slides and come to the next question? Next slide, le lijiye. Iski bhi next mein. So, Dr. Day, one more thing. Are there any other prophylaxis that we offer routinely to the patients who are HIV positive and we have to give them to the antenatal patient? And in this patient, as she is in first trimester, would we offer this prophylaxis to them also?
The other prophylaxis means it is the prophylaxis
Next slide,
respiratory infection of pneumocystic carina. Yes. Hello. Yes. Yes. The mainly of the, but initially the opportunity infection for prevention of particularly pneumocystic carina. But whether to start with the CD4 count, I am not sure that to give prophylaxis to be started with depending on because the CD4 count is not frequently done into the antenatal mother also. And WHO also said that the clinical stage 3 pressure, the only prophylaxis is the cotrimoxazole is the adequate dose for the pneumocystis carina prevention or sulfamethoxazole and trimethamine. That is a double dose. That is the what is called the what is Septan DS or something like that. It is the 800 milligram and 600 milligram of sulfamethoxazole and trimethamine. Yes.
So, CPT prophylaxis, we all are aware that patient is on CPT. So it is given when the CD4 count is less than 350. Although we said that we are starting ART irrespective of the CD4 count, but we are doing CD4 count at beginning before starting ART, and every 6 months CD4 count is repeated. So if it is less than 350 any time during the course of the illness, the patient is started on CPT. And even if she is in the first trimester, she needs to be given CPT. Patients who have some allergic reaction with the sulfa drugs, so there, although alternative regime is Dapsone, but in pregnancy, we will not give this. So we can always have to take care of this problem then. But otherwise, irrespective of the gestation, CD4 count less than 350 or WHO clinical stage 3 and 4, CPT has to be given. Next slide, kar dijiye. Yes, Dr. Rimsey, Resmi, Dr. Resmi. Dr. Resmi, are you there? There? Hello? Hello?
Hello.
Hello? Yeah.
Rashmi, I think not there. Should I answer?
She's not. Yeah, please.
Yeah,
So we just know how do we manage HIV positive women in the intrapartum period?
In intrapartum, actually, we will manage like any other patient.
Please change kar dijiye. Yeah.
So there is no extra fetal monitoring. We have to minimize as few vaginal examinations as possible. We should avoid prolonged labor as much as possible, and we should consider the oxytocin to shorten the duration of the labor. We should avoid during doing ARM. Artificial rupture should be avoided. And delayed cord clamping, we should use non-invasive fetal monitoring. We should avoid invasive procedures as much as possible, safely. I mean, avoid routine episiotomy. We should minimize the use of forceps or vacuum extractors, obviously. And we must clean the baby with a dry gauze. And we should continue the ART intrapartum. So these are the things we should be careful about during the intrapartum period.
Yes, ma'am. The important thing is that we should not do artificial rupture of membrane. Yeah. We should preserve membrane for as long as possible. Because after 4 hours of rupture of membrane, the risk of transmission increases. And delayed cord clamping, as in any other patient, we would do delayed cord clamping here also. There is no need to clamp the cord early. We give this advantage to the baby by doing delayed cord clamping. And very important thing which ma'am has also highlighted, that continue ART in the intrapartum period. Remember that her dose is due, even if she is in labor, that dose should be given to her. So next slide, kar dijiye, please. So this question also was for Dr. Resmi. If you can take up, what are the indicators of cesarean section in HIV positive women? And what
Yeah,
precautions should we take during cesarean?
Again, here it is only for obstetric indication. Just because she is
Next slide,
HIV
Kavita.
positive,
Yeah.
we are not going to do a section. We will do only if there is an obstetric indication for the procedure. And WHO guideline actually for the resource-rich countries offer vaginal at 36 weeks if you can. Depending upon the count, you see, if it is more than 1,000, we can offer LSES. And if the VL is more than 50, we should consider, and if more than 400, we should offer. That is for the for the lesser countries, not resource rich. They are not so much resourceful. If the viral load is more than 1,000 copies per ml at or near delivery, then what we should do is we should give IV zidovudine 3 hours before the cesarean, 2 milligram per kilogram in 1 hour, 1 milligram per kilogram per hour for 2 hours. We should be giving in case we are forced to do a cesarean.
Yes. So thing is that for NACO guideline and WHO guideline for resource limited countries, they say that cesarean section should be done only for obstetric indication. But yes, for resource rich countries like US guidelines, also ACOG, it says that if the viral load at 36 weeks is more than 1,000. Now, we can have any kind of patient, coming to us, like, so you may not, in that case, you may have to decide if she says, because patients are literate, they do ask you about it, and we may get their viral load test. So we should all know that if this is the case, then we may go ahead if the viral load is higher in the women. So we may accept this. This British guidelines are very, very strict. Like for them, they say that they do not want any mother to child transmission. There, even the breastfeeding is also discouraged. So there they take viral load of less than 50 as that patient can deliver vaginally. On that, they advise that cesarean should be done, and definitely if it is more than 400, because although the risk is 2.4%, but still they would say that you go for cesarean section. But in India, yes, it is only for obstetric indication. And if viral load is high, then IV zidovudine. But unfortunately, in India, we do not have viral IV zidovudine. But you can still give tablet zidovudine with a sip of water in case you are having high viral load patients coming. And what are the precautions that we should take during the cesarean section? Next slide, Kartije.
Yeah. The membranes are to be left intact till the head is delivered. And we should use round tip blunt needles. Don't use fingers to hold the needle. We should hold it with a needle holder only. Don't use, some places they hold the needle with the finger. It is dangerous. You hold it only with the needle holder. And for disposal of the tissues, placenta, and other medical and infectious waste material, we should use the standard waste disposal management guidelines. They should be followed strictly.
Yeah. So we have universal guidelines in place. So there is nothing additional required. So all those universal guidelines for the disposal of sharps and other waste should be followed. Next question pe le lijiye.
Yeah. After the precautions in the OT, in the theater, is after the surgical procedure, once it is done, we should rinse the gloved hands in disinfectant solution. And we should wash the hands after removing gloves, and the instruments also should be disinfected, washed, and sent for autoclaving. And we should dispose the sharps as it is there in the guidelines. Sharps should be disposed of.
So now, many a times, because in India, especially in the government setup and at times in the private setup, the situation may come that a woman has come in labor and she has never got tested for HIV. So what type of HIV test can we offer her in labor HIV testing that we say? And if she turns out to be positive with this one test, because we say otherwise we have to do strategy 3. But now it is an emergency situation, patient is in labor and she has tested positive. So how should we manage her in this case?
Shelvara.
Hello? Yeah, Shelvara.
I think we can go for opt-out screening for her again. And with that finger tip trick, with that we can do the KITS test firstly. And if comes over positive, then again we have to repeat it 2 times more. And if it is negative, it's well and good. If it is positive, definitely already sir has told, if we have to start the first dose and then we can go for the further delivery procedures.
So we'll do in labor test the kits which are available. They are the finger prick test kit are available. So you can have the result. If positive, you will not have time now to repeat the test. So with TLD, give 1 dose of TLD, and then next working day you can send the sample to the ICTC or PPT-CT for further testing. And if that sample she is diagnosed as positive, she is linked to the ART center. But till the time such linkage takes place, the ART is continued from the PPT-CT, and also the baby is also given the ARV drugs, which will be, we'll talk about which drugs the baby should be receiving if the mother has not received the ART before the labor. So next question to Dr. Sarkar again. How will you manage the baby born to HIV positive mother? Like we have talked about 2 women. One woman where the HIV testing was done at 2 months and she was started on ART. And this third case which we talked about when she came in labor and then she turned out to be HIV positive. So is there any difference between the both management of the baby in both cases?
Not much, because we have to give the baby prophylaxis with nevirapine. Actually, we divide the mothers in low risk and high risk category. And ideally, all mothers, if possible, should have a viral load tested at around 32 to 36 weeks. And if the viral load is less than 1,000, the mother is treated as low risk. The baby is also treated as low risk, and immediately after birth or as soon as possible, definitely as fast as possible, we should give nevirapine syrup. And we should also counsel the mother for exclusive breastfeeding. But if the mother is high risk, that is, the viral load was more than 1,000 in between 32 to 36 weeks, or mother viral load was not done at all. We do not know the status, as is the case with both these. Most likely case 2 was low risk, case 3 we do not know, but we definitely we do not know her status. And
yes,
if the mother has not been tested at all, so definitely we'll give, we consider the baby as high risk and also give nevirapine syrup. And if the baby is on exclusive breastfeeding, we should continue for 12 weeks.
Yeah. So can you just the slides? So here it is very important to risk stratify the babies. Next slide ले लीजिए. और next पे आ जाइए, आप ऊपर चलिए. और next slide. हाँ, इसके भी next ले लीजिए. So we have to initiate the ART as soon as possible after delivery and put the baby onto the breast within 1 hour, which are the guidelines for the management for all the children who are born. And here we should have reinforced during pregnancy only that mixed feeding is not to be done. She should have been given time to choose what kind of feeding she is going to give to the baby. And next, Lily, this is a single and dual drug. So this is, important, as sir has just said, Dr. Sarkar, that these patients who are high risk, they should be given dual therapy. Now, the duration of the therapy would depend upon whether the woman is going to breastfeed or not. So if the woman is not going to breastfeed, the baby will receive ARV dual drug therapy for 6 weeks. But all those babies who are going to be exclusively breastfed, they will receive this dual drug ARV for 12 weeks. So this is very important that women who have not received ART for at least 24 weeks before delivery, even if we have not done the viral load, we do not have the facility. So we assume that their viral load is not sufficiently suppressed because 6 months ART has not been taken. So for those babies born to those mothers, dual drug ARV prophylaxis is given. And if it is single drug, we are giving nevirapine. If it is double drug, we are giving pseudovidine and nevirapine both combined. Okay. Next slide kar dijiye. So rest of the immunization and all remains the same, like as for any other woman. Rotavirus vaccine should be given to these babies. Now, next situation, Dr. Brejwala, a woman was tested positive for HIV-2 or maybe HIV-1 and 2. So the babies who are born to these women, so is there any difference in the management of these babies? And secondly, can HIV positive women, like what is the criteria we take in deciding whether she can breastfeed or she should not be allowed to breastfeed?
So basically, those women who had been diagnosed before and they are on 3-drug regime and their viral load is low, as already told by Dr. Sarkar, that they should be given Nevarapine only, and we have to counsel during antenatal period if they are known HIV positive regarding the exclusive breastfeeding or to do the top feeding, but not mixed feeding, as it is now 4 decades of the HIV and there is clear instruction that either they should be exclusively breastfeed, but if they are high risk, then we have to, like rightly said by you, that we have to add Zadovudine as well along with Nevarapine. So if they are opting for exclusive breastfeeding, we will be giving both the prophylaxis if they are positive HIV-1 and 2. And if they are opting for exclusive breastfeeding, then if they are low risk, then and a virus load is low and they are low risk patient, we can give this Nevarapine prophylaxis, because
Next slide, Pradeep.
no mixed feeding is advised.
Next slide. Yeah, so there are two things like next. So, you know, the patients who are HIV-2 positive or who have HIV-1 and 2. So there, you know, we do not give NRTIs to the baby. So here we have to give NRTI. So instead of Nevarapine, if mother is HIV-2 positive or 1+2 both, in place of Nevarapine, we give Zidovudine to the baby. And same is true for the mothers who are on PI-based ART. So there also we do not give Nevarapine. We start them babies on Zidovudine. Next slide, Kartije. And as far as breastfeeding is concerned, we have talked about before also that we do allow them because we know the risk of diseases which are going to be to the baby, the infant mortality because of not being breastfed is much higher than if the baby is breastfed. The harm is much more if we do not let the baby breastfeed. Next slide, Kartije. But yes, we have to do the assessment. Next, एक और slide आगे कर लीजिए. So the current guideline says 6 months exclusive breastfeeding. Then next 6 months, the mother does wean off the baby and add on the supplementary feeding. And she can even continue feeding the baby for 2 years also if she wishes, as in the general population. But important thing is, if a woman says that I do not want to breastfeed, I do not want to take that risk of transmission of HIV to my baby during breastfeeding, then we have to do this AFASS assessment. So this is basically the counselor has to see the affordability because we do not want mixed feed. Maybe today she starts, but she is not able to afford it further. Feasibility. Now, feasibility is very important because, you know, in the family, it has not been informed and the woman doesn't breastfeed, stop feeding. She may be forced, you know, to continue with the breastfeeding and she may have to do the mixed kind of feeding. And accessibility to the safe formula feed and the safe water and all, sustainability, safety. So all these parameters, they need to be assessed by the counselor. And then only woman is helped to take the decision to breastfeed or not to breastfeed. But whatever she chooses, it has to be exclusively. Either top feeding has to, if she's choosing that, so she'll be top feeding only, then there's no scope of again putting the baby on the breast because the baby is, you know, the GI epithelium. So it gets eroded if there is mixed feeding. So in that case, if she has done top feeding and then she does breastfeeding, the virus may invade that eroded mucosa. Next slide, Kartije.
Rekha ma'am, I had one question, ma'am. Rekha ma'am.
Yes, sure.
The question is, you know, patient or the mother may start with EBF, but in the maybe after 1 month or 2 months, she may get ill or due to whatever reason, you know, replacement feed may be required. What do you do then?
So then you put the baby, see, there are very few indications of stopping breastfeeding. But if there is any such indication that the mother has to stop breastfeeding, then you completely shift over the child to the top. See, the problem is once you top feed, this is what I was trying to say, that if we see what is the reason why we are not allowing, once you top feed, this is a antigen which is a different antigen for the baby. The gut epithelium will respond in a different way. And whenever there is loss of integrity of the mucosa because of some these basically the antibody reactions that may take place, and if she is continuing to breastfeed also, the organism is going to come from breastfeeding. So if you have to top feed, then stop breastfeeding. Do not continue both on the same time. After 6 months, we expect the GI epithelium to have matured. So after that, if she's continuing, like she's additionally adding supplementary feeding, the harm will not be there. But when this child is small, at that time, mixing should not be done. So because of the immature GI mucosa, if for some reason she has to put the baby on top feed, then she should not again start breastfeeding. We cannot combine that now she has recovered, she is fine, so let her breastfeed. Then the baby should be continued on top feeding.
Right, madam. Thank you.
Yeah. So do we have time to take further questions? Dr. Sweety?
Rekha, how many questions are there now?
मैम अब तो वो कॉन्ट्रासेप्शन था और हमारा वो है बेबी का जो अर्ली इन्फेंट डायग्नोसिस.
Another 10-15 minutes.
Okay. So, Dr. Brajbala, can you please answer this question? What contraception can you offer to HIV positive women?
So basically,
Next slide,
HIV patient on ART treatment, these drugs are enzyme inducers or inhibitors. So we can give them, of course, IUCDs are not indicated, but dual method, barrier method is must to prevent the other STIs, and along with that, we can give oral contraceptive pills or POPs. So, but dual protection is must for them to prevent other infections.
Yeah, next slide, Kadije. So if we see MEC, WHO MEC criteria, so if you see that all these contraceptions that we are giving, they are all either category 1 or 2, except for high-risk HIV positive women, where or women who have, who are stage 3 and stage 4. They are also intrauterine devices. If woman is already using, you may continue to use, that is category 2, but initiation comes under category 3. So as far as, although there are reactions of these drugs with estrogen and progesterone, but still it is still coming in category 2. So actually speaking, there are hardly any contraindication except for IUCD, and that also if the woman has advanced stage disease, and if the woman is already using, you can still continue, but the starting is basically has to be assessed with category 3. If you do not have any other, then you may go ahead with it. Okay, so the message is that you can use oral contraceptive pills, you can give injectables, you can give implants. They are all category 1 and 2 drugs. So next slide, please. Dr. Dola, can you please answer like this question? Very important, early infant diagnosis, and it is part of PPTCT. So we all should know about it. It is being done at our PPTCT center.
Yeah. Early infant diagnosis is actually all the HIV exposed babies
Next slide,
will be tested at 6 weeks of age by HIV-1 PCR test. And if the baby is PCR positive by the first dried blood spot sample, then second dried blood spot sample will be collected for confirmation. So after that, so we are testing all the babies. Then after that, what will happen is, suppose there is a national testing algorithm. Next slide. So actually, according to the national testing algorithm, next slide. Next slide. Yes. So the advisory one has to be followed for all these infants. So first we have to determine the age of the child. Okay. So after determining the age of the child, 6 weeks to less than 6 months, we have to follow the arm A of the algorithm. And 6 to 18 months of age, we have to follow the arm B. And we have to follow the advisory 2 if the child is found to be HIV infected. And advisory 3 is to be followed if HIV-1 is not detected or HIV antibody is negative. So that is basically the crux.
Yes.
Now, if you want
Basically,
in more,
all the babies will be tested by dried blood spot test, and it will be sent for these dried blood spots will be sent for PCR testing. So this PCR testing is done at 6 weeks of age, and if a sample is negative, then we consider it negative for the time being. But at 6 weeks, another thing which we are going to do is we are going to start CPT to the baby. So all the babies who are exposed to HIV positive mothers, in them at 6 weeks, CPT is started. And then a repeat testing of these negative babies will be done at 6 months of age. But now at 6 months of age, we not directly go for the PCR testing, BBS testing. We'll first do the ELISA test. So ELISA in babies is done that all 3 samples are put up together. We don't test 1 and then put 2 and 3. So all these 3 tests are put together. If the baby comes out to be positive, then only, because see, at 6 weeks, we know that the maternal antibodies will be there. So we do not waste our time by doing the antibody testing. We do the antigen testing, PCR. But at 6 months, we do the antibody testing. There is a possibility that the maternal antibodies have gone. But if the antibodies are present, it could be of the maternal origin or the fetal origin. So then we repeat the test by DBS again. The antigen testing, the PCR testing is done. And like we do not, initially we were doing the PCR testing at 6 months also, but now we do first ELISA. If that is positive, then only we do the testing with this. But if baby comes out to be positive, anytime baby started on ART, but this baby will be labeled positive only at 18 months when ELISA testing would be done, because ELISA is still the gold standard. So we will start the ART to the baby, but final testing and labeling of the baby as HIV positive will be done at 18 months of age. Yeah, when you do that full standard test. So this is basically all that we had to talk about. Then we had few questions related to post-exposure prophylaxis, but I think we can, I'll just, next slide, kar dijiye. Yeah, Dr. Devishri, she was there, na? So,
Yes, ma'am.
yeah, can you please tell us basically about the post-exposure prophylaxis? Like anyone who has got injured during needle stick injury has taken place while doing a cesarean section, and it was an HIV positive patient. So what should be done, and we contact? And if we are in a private sector, what all facilities should be there, available there? Because any of your healthcare worker can come with a needle stick injury anytime. So we should have some setup available. So next slide. इसके previous slide कर दीजिए आप एक. Yeah. So अब next पे आ जाइए. So this is the question.
Yes, ma'am. It all depends upon the type of injury, the intactness of the skin, the volume of the fluid, and what is the type of the body fluid that has spilled over the victim. It all depends upon that, ma'am. Whether it is a wide bore needle or is it a deep prick or just a superficial scratch. What is the integrity of the skin, or whether it is a solid needle, and what is the volume or amount of the body
basically,
fluid.
So here, you know, in
No
our
need to
case,
panic.
this needle was solid, because we had injury with the needle while suturing. So this is a solid needle. Okay. So this solid needle will either be exposure code 2 or 3 that I have been highlighted here. So with this exposure code, so basically we should have 2 algorithms in our emergency available, because when someone comes with an exposure, we have to do exposure code and source code. So this is the table for the exposure code. So very clearly you can see in our patient, the exposure code depending upon whether it was superficial scratch or it was a deep injury. She'll come in exposure code 2 or 3. Next slide, Leniche. And this is for the source code. Source code means where it is negative, or we do not know about it, or maybe the woman's titer, we know about the viral load and the CD4 count, whether the viral load is less, CD4 count is high or the otherwise. So according to that, we categorize the source code. Okay. And next slide, Karniche. And then we have that we know the exposure code and we know the source code. So according to that, we recommend whether it is required or not. So I think it is very important that all of us should have these 3 tables in our emergency block. And whenever any person comes with the history of needle stick injury or exposure to the fluid, we should be able to calculate the exposure code. We should be able to calculate the source code. And then from this table, we can see whether it is required or not. Because every time, a person comes, everybody becomes so hassled in the emergency room that whether we should advise or we should not advise. So these 3 tables, I think we should all stick in our emergency rooms, and we should have some ART available to be started before they can, next day or whenever the next working day is, and they can visit the ART center. Okay, so this is the basic aim of putting this question. Next, the question for kar lijiye. And can you just tell us also for hepatitis B, what is the recommendation? Next table kar dijiye.
Hepatitis B vaccination is a must and should, ma'am. Initial of 3 doses, 0 dose, after 1 month, 2nd dose, and after 6 months, third dose. And also booster doses are required, ma'am.
Yeah. So if we do not know the titers of the person, then it is only booster dose. There is no recommendation by NACO for immunoglobulins. So that is something which we should all know, because that time the people, they keep thinking, kya kare, immunoglobulins lagaye. Vaccinated people, if you do not know about anti-HBs titers, then go for a booster dose. Not vaccinated should take vaccine. Ideally, all the healthcare personnel should have received complete vaccine. That is B. For C, we do not have any, vaccination. Next slide, kar lijiye. And quickly, I'll go to the last question, which basically I had put up. The next question पे आ जाइए. एक और आगे कर लीजिए, 2 और आगे जाएंगे. हाँ, इससे भी next में आ जाइए. Yes. So this question, many a times it happens. Vomiting कर दिया, वो eyes में splash हो गया. So क्या करें? So this is Dr. Nagina. Can you please, would you like to come in and?
Definitely, ma'am. Family members are panicked if they are having some contact with that. But whatever the fluids are, there should be some body fluids, that is blood, semen, and CSF fluids, whatever the direct body fluids, and they are the definitely worrisome. And already you had told me whatever the regimen you should be starting, and the other fluids which we should not be concerned about, that is tears, sweat, urine, the vomiters which are already asked for the question. Definitely she needs only reassurance, counseling, and if any time again they are panicking, the placebos, the multivitamins. That's all.
Yeah. So basically, if these tears, sweat, urine, feces, saliva, sputum, vomiters, if they're not contaminated with blood, they do not carry HIV. So I think, in fact, it is not for the relatives and all. Healthcare personnel, they panic more. So these tables, those 3 tables and this table, I think we should laminate them and keep them on our desk, or, they should be kept in the emergency rooms. That person knows, yes, I do not have to panic, because taking ART for 28 days is not a joke. Like, it is, really a very harsh medicine and unnecessarily should not be given. So just see the exposure and the source and accordingly take the decision. Next slide. Thank you so much. And I'm really thankful to all my panelists for putting up the answers so well and preparing so much for this panel. Thank you so much, everyone.
Thank
and
you,
thank
Dr.
you,
Rekha
You can
ma'am.
stop
organizers.
sharing.
Thank you so much. Particularly the
Thank-
last question about the vomiting, because I remember a case of my nursing staff. She made chaos in hospital. The patient vomited on her and universal precaution was written and that day. So this is very important question. Thank you so much.
One thing, Rekha, I would like to add here is that,
Yes, ma'am.
when you're, because we are all a team of people when we work in a hospital. So whenever
Yes,
any
ma'am.
this kind of accident takes place, we have to be very human, very, very,
Yes, ma'am.
sympathetic to the staff, and we have to, even if, because it involves their psychosocial aspect also. So even if we need to give them a paid leave, we should give them.
Yes.
Even a
Yes.
psychiatrist counseling is very, very important.
Actually, there is a provision for paid leave if the person have to take ART, because it does have side effect, and we should realize this also. And recently only, one of our interns came to me. He was giving ARS to a dog bite patient, and when he was pushing the ARS from the wound splashed into his eyes. So he immediately washed the eyes. He came like, should I take the ART? What should I do? It was the evening time. So I showed him these, tables. I said, see, how you see and he said, should I get the testing of the patient done? Because I don't know. I said, no, we have provision for unknown also. So you see where you stand. And accordingly, even if she's HIV positive, she's a healthy person to look at. So viral load will not be very high. So just put up in this table and see whether you need or not. So he was quite happy. Yes, I do not require it. So, but many
I think
times,
post-exposure prophylaxis itself is a lecture,
yes,
which
ma'am.
you have covered in such a short duration, and it's so required for each and every practicing gynecologist to know. Especially when you talk of the post-exposure prophylaxis, we talk of HIV per se, but it is equally important to talk about hepatitis, which you have very beautifully covered. Because
Yes.
hepatitis per se has a more chance of a person getting infected with hepatitis as compared to HIV. So that is so very important, and every practicing doctor, maybe a gynecologist or anybody, should know about post-exposure prophylaxis. It is so very important.
Thank you, ma'am. Thank you so
Thank you,
much.
ma'am. Thank you so much for including us, the Chandrapur. Thank you so much.
Thank
Thank
you,
you,
ma'am.
Rekha ma'am, and have a
You are
safe
welcome.
journey.
Chandrapur
you,
is very, very near to my heart. I have lots of friends in Chandrapur.
Yeah, indeed.
Yeah. So what do you, Sini, for vote of thank? A short vote of thank.
Thank you so much, everyone. Thank you so much, Anju Soni ma'am, for this wonderful session. And we all know how passionate she is about HIV because she was a chairperson of the HIV and AIDS Committee of FOXI. So it was very natural.
Before everybody logs out, I have a very, very small, gentle request to each and everyone that I'm going for the post of Vice President from West Zone. And the elections will start from 1st of August. But before that, each and everyone, I have to verify your mobile number on the portal so that when actual voting starts, your mobile number is not said to be wrong or something. So please, each and everyone, go through this exercise also. I'm sure.
Ma'am, after winning, come to Chandrapur.
Yeah, I'm gonna come. I'm going to come.
But after
So
winning,
what do you,
after
Sini?
winning.
I'm sorry I stopped you because
Yeah, yeah, sure, sure.
I always